Over the next several lecture segments, we're going to be investigating survey and contrast radiography of the small intestine, and we're going to start that off with some basic principles of evaluation of the small intestine. Abbreviations I'm going to use over the next several segments are here for your studies. Objectives are probably not too surprising. We're going to look at what procedures we can choose, what the different advantages and disadvantages of those procedures might be. We're going to look at the normal small intestinal appearance, focusing on survey radiographs and contrast radiographs, recognize the limitations of those radiographs, and understand when obstruction might occur and what we might see in cases of obstruction, and then look at survey radiographs both initially and kind of down the line as repeat radiographs, and then again look at other diagnostic tests, especially upper GI series, colonogram a little bit, and then we'll kind of leave some of those later bullet points for other lectures. And then finally, the big differential diagnoses that you're going to need to evaluate: obstruction, functional ileus, and lesions of the wall, including rupture of the GI tract. So here's what we're going to hit over the next 100 minutes or so. We're going to start off with a general workup, of course. And so we first have to think about what sorts of bad things can happen to the small intestine. One major thing that we see is some sort of change in its ability to move ingesta/digesta down the tract. So that may increase, the GI tract may be hypermodal, or it may decrease and it's hypomodal. The intestine can be obstructed, so decreased patency. A lot of times that is due to some sort of intraluminal object, some foreign object, but you can see masses or other infiltrates of the wall. You can even see extramural masses outside the GI tract compressing the intestine and resulting in obstruction. Loss of integrity, so rupture of the small intestine or any part of the GI tract, is going to be really important to identify. The sooner the better. And then any sort of change in the mucosa can happen to the SI, but imaging usually isn't very helpful for this. Ultrasound can be somewhat helpful to a degree, but radiography isn't going to be nearly as good for mucosal function and even mucosal structure. So there are a number of reasons clinically that you might be concerned about the small intestine as the source of the problem. Certainly any sort of GI tract signs would be a concern. So vomiting, diarrhea, abdominal pain, all of those can be attributed to the small intestine, although certainly none of those are specific. You do have to look at the whole patient and not just images to sort out what's going on, because there are a ton of differentials for vomiting and diarrhea. And so on the left side, I've put the main small intestinal diseases, but certainly we can't forget the stomach, the large intestine, other abdominal problems. Pancreatitis is always a big one, cancer, metabolic disease, don't forget, kidney disease, hepatobiliary disease, a number of problems. Again, in this lecture, we're going to focus more on the first column. So gastroenteritis in all of its forms and causes, inflammatory bowel disease, so chronic inflammation, causes of obstruction and infiltrate. So lots and lots of possibilities here. So we have to know why we're taking radiographs. Ultimately, we would love to know if a given patient does or does not have small intestinal disease. That would be great to rule it in, rule it out definitively. And sometimes we can do that with imaging and sometimes we can't, because radiographs are not overly sensitive when it comes to, again, some of those mucosal diseases, inflammation, so enteritis, IBD. So kind of a global what disease does this dog have is probably too much to ask of radiography. But if we think about it a little tighter and ask, does this dog have something that we're going to need to go to surgery for, then you're going to find that radiographs are going to be a lot more useful. So one thing, is this dog obstructed? Is there a small intestinal or other gastrointestinal obstruction? If there is, can we figure out what the cause is? Is there a foreign object? Is there a mass? Is there an intussusception? We may not always find the cause, but radiography can often at least identify that there is an obstruction and thus that this dog needs surgery. Another surgical emergency is a mesenteric volvulus, twisting of the small intestine around the mesentery such that there's vascular compromise. Those dogs, or cats, it's much more common in dogs, will die if they don't get emergency surgery. So that is something that we need to be able to identify rapidly, and that's something that we can do with radiography. Small intestinal rupture, similar story. This is something we need to figure out. Radiographs are of medium, we'll say, specificity for this. With small intestinal rupture, we usually see peritoneal effusion, which we can see in any number of diseases, so that's not very specific. But If there's a pneumoperitoneum, and often there is, then we can be a lot more concerned that there's some sort of GI tract rupture, although again there are other causes of gas in the peritoneal space, such as external wounds. Beyond the GI tract, radiography can help us determine if there's some other cause for the patient's clinical signs. Are the kidneys big? Is there a kidney mass? Is there a hepatic mass, a splenic mass, big sublumbar nodes to suggest cancer or fungal disease? So lots of other things that could relate to the clinical signs that may not be gastrointestinal. We get that global view, which is really useful. And then, you can kind of put all the different findings together. Maybe you see some intestinal disease, but you also see disease elsewhere, lytic lesions in the bones, or like I put here, pulmonary nodules. Even if you don't see a cause of obstruction, you're going to have to be concerned about cancer when you put all those parts together. So things to think about really as we go forward. Where do I want to start, and then where do I want to go from there? Survey radiographs are very useful for any vomiting dog or any dog with diarrhea where you're concerned about GI disease that you want to work up. After that, what you see will kind of dictate where you go next. Maybe you have an answer and you can go forward with your treatment plan. Otherwise, you may need to repeat radiographs in a while and see if things change, do an upper GI series, or use some other modality of identifying disease. So once you've decided that radiography is a good place to start in a given patient, you need to know what to expect when you're looking at the small intestine. And as always, we're going to describe our findings in terms of the Röntgen signs that I've listed here on the left. That last bullet point isn't really a sign, it's just kind of a reminder to me that we're going to talk about the findings not only in terms of survey radiographs, but also in terms of contrast radiography. And again, most of the descriptors are pretty similar. So if we start with location, thinking proximal to distal, starting at the duodenum, remember the duodenum starts at the pylorus, so we may or may not see where that connection point is. It tends to be closer to midline in a cat than it is in a dog because of the stomach shape. The descending duodenum moves along the right cranial abdominal wall, and it's usually the most lateral intestinal loop you're going to see. And that's useful if you're trying to differentiate who is duodenum and who is large intestine. As you get to the rest of the small intestine, everything's a bit more variable. The jejunum represents most of the small intestine, but it can kind of move around, so it doesn't have a precise location in any given patient. And then the ileum is very short and usually can't be specifically identified as a discrete part of the small intestine, at least in terms of survey radiography. So here we have a normal fat cat. He's not here with GI signs, he's here for urinary issues, so his GI tract is normal. And one thing that we see is that there is a ton of fat. Lots of sub-Q fat, lots of retroperitoneal fat, lots of peritoneal fat. So it creates a very nice contrast in this patient. We actually can see the small intestine and the other soft tissue structures really nicely. And what we notice here is that the small intestine is gathered in the midventral abdomen. Same cat, ventrodorsal view. Again, we can tell that it's very quickly tell that it's quite fat. And once again, all of our intestines are kind of gathered in one area, and here it's on the right. And what's important to note here is that this is normal in a fat cat. Fat cats generally gather their intestines on the right side and kind of mid-ventrally. It's not that this is bunched or plicated, which we'll talk about later. This is a typical appearance, that they don't have uniform distribution of the small intestine. It's just how it is. So when we're looking at a small intestinal segment and trying to determine who it is and where it might be, we have to decide if a given segment, especially if it's big, is excessively dilated small intestine or potentially normal large intestinal segment. And that's going to be really important as we try to decide if a patient may or may not have an intestinal obstruction. So when I'm trying to figure out who's who, one thing I'll often do is start with the kind of assumption that maybe everything's okay. Try to figure out, could this all be colon, or is something an outlier such that there's no way that all of this can be colon? And so I can start caudally a lot of the times and trace the descending colon to the rectum, and so that's always a nice starting point, and then kind of go from there and look and see, are there too many intestinal segments to all be colon? If you have multiple distended segments, it may be too much to all be large intestine. Or is the position of one or more of those just too weird to be large intestine, in which case you're stuck with it being small intestine and then potentially abnormal. As you're trying to figure out who's small intestine and who's large intestine, remember that fecal material can look like foreign material. So normal stuff in the colon can look like abnormal stuff in the small intestine. The gravel sign, as we'll see in a partial obstruction, may be in a small intestine, and it can be confused for fecal material in the large intestine. So the heterogeneous stuff that you may see in the lumen may or may not be helpful in determining what a segment is. If you can't figure it out on the survey radiographs, you can always repeat radiographs, get other views, do a colonogram, again, to identify who's large intestine, and then by exclusion, figure out who the small intestine is. So here we have a cat, figuring out who's who. Here we have a number of gassy intestinal segments and then a larger gassy intestinal segment. And this one's relatively straightforward because I can follow the big gassy segment all the way back to the rectum, so I'm very comfortable that this is large intestine, and it's nice and continuous and a reasonable size and shape for large intestine, location for large intestine, a little bit of plausible fecal material here. And so all the big part of intestine really seems like it's going to be large intestine, and that's okay. Everything else is much smaller and is a reasonable size for small intestine. So there's really nothing too concerning on this one because the large and small intestine look different enough that they're fairly identifiable. Here's that same cat on a ventrodorsal view. Again, the appropriate location and shape of the colon, a little bit of fecal material in there. Everything else is small intestine, and again, this is very believably large intestine, so I'm not going to be too concerned about the size of this intestinal segment because, again, I don't think it's small intestine. Here we have a dog who also has a few distended intestinal parts, and we have to again decide, do we think this is all large intestine or might it all be small intestine? I can see a little bit of the large intestine, the colon going to the rectum back here, but it gets tough to follow as I go further forward. Could these plausibly be large intestine, both of them? Maybe some of it's descending and some of it's ascending. Possibly, although the ventral one's a little further ventral than I would expect for large intestine, so it's a little iffy in this case. I'm already concerned that maybe not all of this is colon, but it's not a guarantee yet. So we move to the VD view, and now I see that there are these same two gassy loops superimposed on each other, a little more toward midline than I would like, and kind of crossing midline. If this were transverse colon, I'd like to see it a little more cranial, and in fact, this may be transverse colon right here, so I'm still concerned that that's small intestine. And then I look and I can find, wait, there's material that looks like fecal material in this loop, and that really is very believable for the descending colon. So if that yellow outlined one is descending colon, then those two pink ones can't be large intestine. Thus, they're small intestine. We're going to find out later those are too big, and so I'm going to be concerned about an obstruction on this guy. And then going back again to the lateral view, I do see not only the large kind of distended small intestinal segments, but there are some normal ones too. And so again, as we'll talk about later, this indicates that there are two populations of small intestine, and that's pretty much a slam dunk for an obstruction at this point. You can see intestines in an abnormal location because of external problems, so a mass effect from some other organ, liver, spleen, etc., or entrapment in some sort of hernia or body wall rent. And then you can kind of have that anywhere of the GI tract. Inguinal is reasonably common, but any sort of body wall hernia, diaphragmatic hernia, often we'll see intestinal segments in the thoracic cavity at that point. Sometimes they may be easily reduced and may not be causing a clinical signs, but sometimes the act of herniation also results in obstruction or may result in other incarceration or ischemia, and so then it may become a surgical emergency. Here we have a cat, and I think it's fairly readily apparent that there are some gas bubbles in the soft tissues of the ventral thoracic wall, certainly where they don't belong, and then we see this tubular structure that extends kind of toward those gas bubbles and then back toward the abdomen. And so this was a case of body wall hernia that contained both large intestine and small intestine. In terms of counting number for the Röntgen findings, no one really wants to count the exact number of small intestinal loops. So that's not really the focus of this section. The real focus is going to be when we see an abnormality, does it affect all of the small intestinal segments or only some of them. And so if we see an abnormality that's diffuse, so affecting really all or most of the small intestine, that's more likely to be a functional ileus, a non-obstructive thing. If the dilation is more focal, so a few segments are affected and others are not, that's much more concerning for an obstruction, a mechanical ileus. Here we have a cat with a functional ileus. You can see all the intestinal loops are nice and relatively uniform in their size. They're all a little gassy, but nobody's particularly bigger or smaller than the others. So again, this would be typical for a functional issue like a gastroenteritis. Here we have a mechanical ileus where we have small intestinal segments of different sizes. Some are big and some are normal, and so this is more compatible with an obstruction. There are a number of guidelines people use for determining if an intestinal segment is too big or okay. I've yellowed the ones that are probably the most objective, or at least the most rigorous. Again, nothing is set in stone. Nothing can be taken without taking other clinical signs and other radiographic findings into account. So these numbers are a good starting point, but again, you can't take any one measure as gospel. But when you're looking at dogs, if you measure serosa-to-serosa in an intestinal segment, a small intestinal segment should be less than 1.6 times the height of the L5 vertebral body at its narrowest point. And that's pretty cumbersome, but we'll get a look at it in just a minute. As the diameter gets larger than that, you get increasing concern for mechanical ileus. So if it's just a little bit bigger at that 1.7, you're about 50-50 that there's an obstruction. As it gets over 2, the ratio, then you're hitting much higher likelihood of obstruction. So again, the bigger an intestinal segment is, the more likely there's an obstruction. There are other measures that I've got down here. Those are less helpful. This final bullet point is actually maybe more useful than those middle two. The width of any small intestinal segment should be no more than 50% larger than any other. So if you have 1 or 2 or 3 segments that are like twice as big as others, then that's putting us into that 2 populations of small intestine camp, and so that's going to be a concern. Again, it's not specific, but it does get to be more concerning at that point. Cats are similar. Here, normal is considered to be less than twice the height of the L2 vertebral end plate. Again, as that ratio gets bigger, you get greater and greater likelihoods of having an obstruction. That last bullet point is one that has been used for a while. It's pretty good. It can be difficult because you usually can't see mucosa to mucosa. We can see serosal edges, but usually not the true mucosal edge, so it's not as useful in terms of survey radiographs. Maybe a little bit better with contrast radiographs. And that brings us to this next nice yellow important point. We cannot reliably evaluate intestinal wall thickness on survey radiographs. Sometimes we get the impression that there's wall thickness. So if I see gas in the lumen and that gas bubble has a really irregular margin, my suspicion is that it is a gas wall margin, and thus any soft tissue I see is wall, and thus it may be thick. Because if this is truly gas within fluid, usually that gas bubble should have a pretty smooth margin. But again, we don't know that for certain because any fluid in the lumen will silhouette with the wall, so we can't 100% say that a wall is thick on survey radiographs. And we've gone through this before on the kind of principles slides in earlier lectures, but here, if you have fluid in the lumen, it's going to silhouette with the wall. And it's going to give you the impression as you look at it that the wall may be thick, but we don't really know how much is wall and how much is fluid. But again, we see there's a nice smooth margin here because that's what a gas bubble in fluid should do. If this had an irregular margin, then I would be more likely to think that that's not a gas bubble in the midst of fluid, because again, it should have a smooth margin. So if I see that irregularity, there's a greater likelihood that all of that soft tissue opacity is truly wall. And here's a case that I would think that, where you've got this little thin ribbon of gas. I can see one serosal edge here, another serosal edge here. So it's a pretty big intestinal segment. It's kind of chunky. And the margin of that gas and tissue is more irregular than I would expect for gas in fluid. So my concern is that there is gas up against the wall is irregular, and the wall is thick. Small intestine should be tube-shaped. Again, any interluminal gas should be relatively round or oval with smooth margins. It should sit in the middle of the segment. If it's off to one edge, then we're going to be concerned about plication, which we'll talk about later. You will see normal peristalsis, so focal narrowings of the small intestine, but it shouldn't persist in the same spot over multiple images. When we have narrowing that persists, or when we have those irregularly positioned gas bubbles, then we're starting to think about linear foreign bodies or potentially other differentials. The wall is going to be a soft tissue opacity. Interluminal contents are variable, generally mostly fluid and gas. We don't like to see other heterogeneous stuff in the small intestine most of the time. In a dog, usually the contents are about 50-50 gas and fluid. In a cat, usually we see mostly fluid and not so much gas. Mineral material can be of no consequence if it's a dog or cat who eats bones, went out and ate a squirrel. There's going to be mineral stuff and it may not be any big deal, but mineral opacity stuff can also be foreign material, so it's certainly going to be important to decide what you think based on other clinical signs and other radiographic findings when you see mineral stuff in the GI tract. We definitely want to see good sharp serosal margins because the small intestine should be surrounded by fat, and that should give us nice contrast. When we don't have that, then there's high concern for peritoneal disease, whether that's peritoneal effusion or peritonitis or carcinomatosis. The mucosal margins are variable. Like I've said before, if there's fluid in the lumen, we're not going to see the true mucosal margin. If there's gas in the lumen and no fluid, then we're going to see the mucosal margin very nicely, but we don't always know which situation it is on survey radiographs, so an upper GI series is going to be a lot more useful for assessing the mucosal edges. And all edges that you see really should be smooth. There's no excuse for irregularity. That would be abnormal. So as we move to a few points about an upper GI series, think about the transit time. And transit time relates to the time it takes for the first bit of contrast to move all the way through the organ in question. So for the small intestine, in a dog, transit time is 2 to 4 hours, and that's when the contrast medium gets through the small intestine and the first bit of contrast medium gets to the colon. That's the transit. In a cat, it's going to be quite a bit shorter, so half an hour to an hour, but all of these numbers are pretty variable depending on how stressed the patient is in the hospital. If it's sedated, that's going to slow everything down, what the diet is, and so on. So this is a normal cat 30 minutes after we gave contrast medium. You can see that the stomach is nearly empty, the duodenum's mostly empty, and there's quite a bit of contrast medium already in the colon, a lot of small intestine over here as well. So this was normal and again a pretty speedy transit. On an upper GI series, we want to see a nice continuous contrast column. There may be areas that are narrower due to peristalsis. There may be areas that are mixed with gas, so it's not 100% uniform, but we do want to see it relatively continuous. The mucosa is usually pretty smooth. It may have a hint of irregularity to it because of the normal brush border of the mucosa, referred to as fimbriation on an upper GI series. So a little hint of irregularity that's almost too fine to be seen is okay, and again is considered fimbriation. We'll want to see that the mucosa is coated by the barium. If we use iodine, it's not going to coat nearly as well. Pseudo-ulcers, you see that in quotes, are normal structures in dogs, and they're basically depressions in the mucosa where there are submucosal lymphoid structures. Those are most classically described histologically in the ileum, but we actually see pseudo-ulcers best in the duodenum, and there's a little bit of discrepancy in the literature as to what we're supposed to call all these things, and so I didn't put it on the slide, but again, we tend to see these on a GI series as normal structures best in the duodenum, where they're smooth depressions, kind of square-shaped. Here we have an example of fimbriation, so just this really, really fine irregularity of the mucosal edge. That's normal. If there's pathologic irregularity, it's going to be a lot more easy to see, honestly, than this, and also project into the lumen more. And here are some of those pseudo-ulcers. Some will call them Peyer's patches. Again, those might be specific to the ileum depending on who you read, so I'm just going to leave them at pseudo-ulcers. They are normal in any event. And you can see that these are nice and squared off, so they're and still pretty smooth, so they're going to look different from lesions that we see later. I've alluded to peristalsis. There is going to be focal narrowing kind of in different spots in the GI tract as you do your study. We want to see that it's symmetric and circumferential, so there should be an equal indentation on both sides of the wall. If it's unequal, then it's more likely that it's an actual lesion of the wall or mucosa. The margins should remain smooth. If the mucosa is irregular there, that's not normal. And the location should change over the span of multiple views. And it's definitely a lot more apparent in cats, and some will refer to it as the string of pearls appearance. So here we have a normal duodenum in a dog. You can see that there's this really narrow area right there. The contrast medium is continuous, so that's one good thing. Nice smooth margins. It is circumferential. We see narrowing coming from both sides. And if I gave you another radiograph, we would see that it wasn't present on a subsequent view. And here we have the normal jejunum in a cat. You can see it's a lot more active looking. There are a lot more areas of narrowing representing normal peristalsis. And you can see how some areas go from larger to smaller to larger to smaller, all in a chain. And so how it might have gotten that string of pearls sort of name. So that will do it for this part of the small intestine. Next, we will move on to various types of pathology of the small intestine.